introduce Professor Dario Rahelic from Croatia. Professor Dario Rahelic is the president of the Croatian Diabetes Association and chair of the Diabetes Center, the most important diabetes center in Croatia. And Professor Dario Rahelic is going to talk about diabetes and cardiovascular disease. Professor Dario.
Thank you very much, Professor Schaut. Dear colleagues, thank you very much for your kind invitation. It's always my pleasure to support AASD Association and my dear friend, Professor Schaut. She's doing great things in diabetes in Egypt, so it's my pleasure to support her, and it's my pleasure to accept this kind invitation. I would like to express my gratitude to Professor Schaut and the organizing committee for inviting me to be with you, at least virtually, at World Diabetes Day. This is a very busy day for all of us, but it's my pleasure to be with you right now. And it was my pleasure to be in Cairo less than 2 weeks ago. So when we talk about diabetes and cardiovascular disease, we have to say that type 2 diabetes is a major and independent risk factor for both macro and microvascular complications. And we know that type 2 diabetes affects multiple organs, increasing patients' comorbidities, including not just cardiovascular, but also cerebrovascular disease, kidney disease, nerve damage, eye disease, and diabetic foot as well. But when we talk about cardiovascular events, we know that, and even microvascular events, we know that endothelial dysfunction is the most common risk for micro and macrovascular complication. In the heart, remodeling or hypertrophy of cardiomyocytes will lead to myocardial infarction and heart failure. On the other side, remodeling and plaque formation in blood vessels will cause stroke, peripheral artery disease, and also aneurysm. And microalbuminuria, which is very common in type 2 diabetes and in type 1 after many years, also can cause overproteinuria and end-stage renal failure. Key manifestation of cardiovascular disease is, of course, coronary heart disease. But the coronary heart disease is not just macrovascular complications. Usually, when we talk about myocardial infarction or coronary heart disease, we always think about macrovascular complications and complications, atherosclerotic plaques on huge blood vessels. But also, beside huge blood vessels, we have small blood vessels, and also we have cardiomyopathy, ischemic cardiomyopathy and diabetic cardiomyopathy, and we cannot say that heart disease is just macrovascular complication. It's also microvascular complication, and heart failure was many years was underestimated problem in diabetes. We can say that the same in stroke. Usually we think that the stroke is the consequence of atherosclerotic plaques in huge blood vessels, but also it's not just macro, it's also microvascular complications as well as peripheral artery disease. Unfortunately, many years before the onset of type 2 diabetes, or at least the time of diagnosis of diabetes, we know that insulin resistance was present at least 5 to 7 years. On the other hand, we know that beta cell function is decreasing more than 5 or even 10 years, and development of macro and microvascular complications start much earlier than we have time of diagnosis of onset of diabetes. And we know that the diabetes doubles the risk of vascular events, and we know that people who have diabetes, they have at least twofold higher risk, even more than twofold higher risk for cardiovascular disease, especially coronary heart disease, than people without diabetes. That's the reason why landmark publications suggested that type 2 diabetes may be a cardiovascular risk equivalent, because we know that people with diabetes, with no prior myocardial infarction, they're at same risk as patients with no diabetes but prior myocardial infarction. So myocardial infarction, previous myocardial infarction in people without diabetes is equivalent to risk for people with diabetes and no prior myocardial infarction. We are all aware of Rahelic story, and after 2008, after publications of Nissen and his collaborators, which concluded that rosiglitazone was associated with a significant increase in the risk of myocardial infarction, all industry of diabetes completely changed. And that's the reason why FDA and EMA decided that new type 2 diabetes drugs must demonstrate the no acceptable increase in cardiovascular risk. On the other side, that's the reason why all regulatory guidance to industry on cardiovascular outcome trials have to follow these guidelines and have to demonstrate that the new drugs for diabetes are not cannot increase the cardiovascular risk for cardiovascular infarction and risk of cardiovascular death. But what is the evidence? We know many different clinical trials which has already been published, and many clinical trials are still ongoing. I will not go into details, but beside cardiovascular disease, we have to emphasize the importance of renal disease. And you can see here that people with renal disease also have much higher risk for mortality, and renal disease is associated with increased all-cause mortality. So after this, all drugs have to demonstrate, and they are trying to demonstrate that they do not have negative effect on myocardial infarction risk or risk for cardiovascular disease, but also the risk for renal disease as well. So previously we thought that HbA1c targets have to be as lower as can, but after 2005, after 2008, and after 2015, we learned many different aspects of diabetes, and we as a diabetologist completely changed our attitude to people with diabetes. And today we know that HbA1c target has to be as low as it's possible, but the level has to be individualized, and also we have to try to target that HbA1 level with no hypoglycemia, with no risk of high risk for mortality, but also with no risk of weight gain and other things. But when we look at cardiovascular effects on good glycemic target trials, we have learned that good glycemic targets and good glycemic control can achieve a reduction in microvascular complications, but not in cardiovascular death and cardiovascular disease. And one of the most important trials was a core trial, which showed that good glycemic control or too low HbA1c in 1% of people who were participated even increased the cardiovascular death and all-cause mortality. So we learned that good glycemic control is okay and it's desirable, but of course good glycemic control without hypoglycemia, and all new drugs right now are prone to have low risk of hypoglycemia just because of lower risk of cardiovascular mortality and hypoglycemia. So, and after many years, we can achieve at least neutral effect on cardiovascular disease or cardiovascular mortality. And recently, or last 7 years, we have learned that some drugs can even have beneficial effect on cardiovascular mortality and cardiovascular death. And before that, we knew that it's important to achieve good glycemic control, but also to approach to all other cardiovascular risk factors as the control of dyslipidemia, antihypertensive therapy, lifestyle intervention and weight loss, antiplatelet therapy, and we knew that that's the only way how to lower cardiovascular risk. I would like to emphasize the importance of good glycemic control as well, and because we know that people with diabetes, especially people who don't have good diabetes control, the life duration or life expectancy is reduced by 6 years, and if people with diabetes have previous cardiovascular events or established cardiovascular disease, their life expectancy is reduced by 12 years. That's the reason why we have so many cardiovascular outcome trials, and I will not go into details. Many trials completed cardiovascular trials, outcome trials for new type 2 agents demonstrate neutral effect on cardiovascular mortality and cardiovascular disease. But some of them resulted with the information that some drugs can even increase the risk of hospitalization for heart failure. And after SAVOR-TIMI trial, we have learned that heart failure is one of the first manifestation of cardiovascular disease, and we learned that heart failure is also underestimated problem in people with diabetes. 2015, we have learned that some new revolution, and we can say that EMPA-REG trial was revolution in modern diabetology, because in EMPA-REG trial more than 11,000 people were screened and more than 7,000 people were treated. I will not go into details because you know all those details, but we have learned that diabetes is cardiovascular disease. And what was a huge result, and I can say that this was one of the most important clinical trials in modern diabetology. EMPA-REG trial confirmed that using empagliflozin beside all standard anti-diabetic therapy, we can achieve cardiovascular death reduced by 38%, all-cause mortality for more than 30%, 3-point MACE for 14%, and also hospitalization due to heart failure for more than 35%. So you can see here that approximately 18% of patients with diabetes have been shown to have first cardiovascular event, and you can see here a number needed to treat it to prevent one patient death across the EMPA-REG trial was 25 for 5 years, and it's much lower than landmark simvastatin trial, or also and also HOPE trial, 4S and HOPE trials with 30 and 56 patients. That's also in that period of time there was also drug safety communication. FDA informed also about decreased bone density with empagliflozin and other SGLT2 inhibitors, and also for with risk of acute renal failure or acute kidney injury, and also about amputation. But after 7 years, we can say that it's very, very rare. Next year, LEADER trial was published, and LEADER trial confirmed that using of liraglutide in comparison to placebo, together with all other anti-hyperglycemic therapy, can reduce the cardiovascular death from 22%. On the other side, 12% reduction in non-fatal myocardial infarction, approximately 11% for non-fatal stroke. And you can see it here that myocardial infarction, but also especially cardiovascular death, was the most important for LEADER trial. And in this moment, we can say that empagliflozin and liraglutide have beneficial effect on the reduction of cardiovascular death in comparison to other drugs from these two classes of drugs. Also, the liraglutide decreased for 12% expanded MACE, cardiovascular death, non-fatal MI, stroke and coronary revascularization, or hospitalization for unstable angina or heart failure. On the other side, SUSTAIN 6, although it wasn't cardiovascular trial, also confirmed the beneficial effect. And you can see it here, the primary outcome was reduced by more than 25%. So when we talk about all those three trials, we also learn not just that they are cardioprotective, but also the renal composite outcomes were reduced in all three drugs, empagliflozin, liraglutide, and semaglutide. In meantime, we have also results of dulaglutide. That was the reason why we have learned that ADA had to completely change their attitude, and since 2016 ADA said that it's important to establish cardiovascular risk, and for people with established cardiovascular disease we have to use drugs which can reduce the risk of mortality, and also it was especially emphasized people with high risk of cardiovascular disease and also established cardiovascular disease. They have to use empagliflozin or liraglutide, and later on they changed it to and all other drugs which can decrease the cardiovascular disease. European Society of Cardiology was one of the first which showed and also named empagliflozin as SGLT2 inhibitors which have to be used in people with cardiovascular disease. But right now in all cardiovascular and also all diabetes guidelines, we can see that SGLT2 inhibitors and GLP-1 receptor agonists are the first drug after, of course, slight modification in metformin to treat people with established cardiovascular disease. Also, we have a cardiovascular risk modification algorithm, which is important, and it's not just about diabetes, also about dyslipidemia, hypertension, lifestyle changes, and weight loss. We have changed our Croatian guidance. The last update was 2016, and right now it will be published very soon. We will publish the new version of guidelines, and even 2016 we emphasized the importance of the individualized approach, and especially we said the risk of complications and hypoglycemia, and we have put 2016 we have put the SGLT2 inhibitors, DPP4 inhibitors, and the GLP-1 receptor agonist immediately after metformin, and or even in the first line if metformin is not tolerated or there is contraindication for metformin. On the other side, we put GLP-1 receptor agonist and SGLT2 inhibitors in all stages, and all as a monotherapy, dual therapy, triple, or with insulin treatment as well. And unfortunately, I could speak a lot about diabetes guidance and about novelties in cardiovascular disease, but I know that this is limited time, and this is the World Diabetes Day, which is day of awareness of diabetes, but we have to be aware about cardiovascular disease. Unfortunately, more than 75% of people with diabetes will die due to cardiovascular disease, and we have to help them. We have to assess their cardiovascular risk and also to treat them to achieve as good glycemic control as we can, but also we have to target their hypertension, dyslipidemia. We have to emphasize the importance of weight loss, proper diet, and physical activity, because like George always said, helping others is good, but teaching them to help themselves, it's even better. Ladies and gentlemen, thank you very much for your attention.
Professor, I really enjoyed very much your elegant presentation. Being a vascular surgeon, I see your lecture is of paramount importance, and from the vascular surgery point of view, we have really felt the importance of the macro and microvascular affection. We have changed from not only revascularization of the supragenicular and infragenicular blood vessels, but further we are now targeted to the below the ankle blood vessels because of affection of the small vessels by atherosclerosis, particularly in diabetics. So we are shifting our care and concern for below knee vessels as well as below the ankle vessels. That's from the interventional point of view. Furthermore, from the diagnostic point of view, the duplex criteria have now added the ankle peak systolic velocity instead of the ankle brachial index due to the heavy calcification of the vessels in diabetics, which give a falsified result of ankle brachial index, and it focuses much more on measuring the blood flow by duplex, not by pressure, in both the anterior and posterior tibial, dividing them by 2 to reach the ankle peak systolic velocity. And furthermore, we are now relying on the resistivity index of the below the ankle vessels in our diagnosis and comprehension of the vascular status of the patient. So I really endorse your excellent message that is very well received due to its importance in the vascular domain. Thank you, sir.
Thank you very much, Professor. As Professor Schaltut already mentioned, I'm chairing the Vuk Vrhovac University Clinic for Diabetes, Endocrinology, and Metabolic Disorders, and approximately 60,000 patients per year with diabetes are treated in our hospital. And we do in the screening we usually do AB index, ankle brachial index, and ECG, and all people with diabetes who are for the very first time in our clinic, no matter, and also annually, we perform ankle brachial index as a assessment of peripheral vascular disease, and also ECG. But also in our clinic we have more than 35 diabetologists. We have 2 cardiologists, 3 ophthalmologists, 3 neurologists, 2 psychologists, and 2 physiotherapeutics. And right now we have 16 residents of diabetes, endocrinology, cardiology, ophthalmology, and neurology. So we are a huge clinic, and we are very aware of the importance of the multidisciplinary approach, as you already mentioned. And we have good connections with our invasive radiologists, and also vascular surgery department, and cardiac surgery department as well. Because more or less, as I mentioned, that majority of people with diabetes unfortunately will die according to cardiovascular disease, and peripheral vascular disease is very important, because if somebody has peripheral vascular disease, it's very probably that that patient already have cardiac disease as well, or ischemic cardiac disease.
Thank you.
Thank you, Professor Dario, for your elegant lecture. I would like to ask you about the GRADE study, a recently published study for metformin and add-on forearms, liraglutide, degludec, glimepiride, and sitagliptin. Interestingly, after 5 years, the liraglutide arm doesn't show significant improvement in the cardiovascular outcome. What's your explanation?
Well, it's very difficult to explain the results of this study, because the study population was different in comparison to the study which involved and study population which was involved in leader trial, empagliflozin or EMPA-REG trial. So when we talk about different clinical trials have different people or study population, also different outcome measures. And it will be interesting to see, because this trial was the first trial which confirmed that maybe the results of previous trials were not as like we thought they are. But there is no doubt that metformin, especially when we talk about metformin is very cheap drug, and who knows what would happen if we would use metformin and have the real cardiovascular outcome trial just with metformin. But we know that metformin is very cheap, and there are so many generic drugs of metformin. So metformin is somehow forget it in the clinical trials. On the other side, we learn also from Carmelina trial that comparison of DPP-4 inhibitors and SU were not as we expected. So that's the reason why we cannot be sure where is the truth. But according to SGLT2 inhibitors and GLP-1 receptor agonists, I would say that in this moment we know that GLP-1 receptor agonists, especially liraglutide, semaglutide, and dulaglutide, and also in SGLT2 inhibitors, especially the empagliflozin, they have enough evidence to say that those class of drugs should be used in people with established cardiovascular disease, and maybe even, as cardiologists say, in people with high risk for cardiovascular disease.
Thank you.
Thank you, Dr. Dario, for your interesting lecture.